Today we're doing a health and safety update, iComply health and safety update. For those of you who don't know me, I think most people probably do by now. My name's Alex O'Neill and I'm Code's Professional Services Manager. What that means is I spend time researching CQC inspection reports, other inspection regimes in Scotland and in Wales, adapting the system and our documents for you so that you can meet the latest regulations and hopefully pass inspections. So we're doing a health and safety update today. The aim of today is to increase the understanding of the new inspection regime and help practices prepare for inspection. So the objectives are to explore topical health and safety issues, to discuss new and updated code templates, and to explore how the iComply system helps you to meet guidance and regulations. The learning outcomes from today, obviously we've only got about 45 minutes or so, but hopefully what we'll be able to achieve is to improve health and safety knowledge in your practice, to feel confident using the updated and new code templates, and to be able to demonstrate to an inspector how your practice is meeting these standards using the iComply system. Okay, so as most of you know, for people who've been following this webinar, we are constantly researching the CQC inspection reports in order to be able to update the system and give you the latest information of what inspectors are looking for. And we have, as of yesterday, a couple of days ago, we've looked at 846 new inspection reports in total. 18% of practices being inspected are in breach of at least one regulation and must make improvements, so they didn't pass their inspection. 68% of practices being inspected have been told that they could and should make improvements. And I had a conversation with the CQC recently, and whilst they won't ever give you a direct answer on these things, but it was like I was saying probably in the last webinar, is that quite often the practices that are trying to meet the standards, if there's an issue, the CQC will pass them on their inspection. And it does seem that the practices who debate with the CQC over the nature of regulations and whether or not regulations should be regulations might have a tougher time. The most practices that are in breach are failing on safe and well-led. Well-led is the big one. And when I asked them, the CQC, how we could help practices, if there was one message that we as Code could give to practices, they hinted that it would be how to be well-led. And a lot of being well-led, we've got a whole webinar on it on our YouTube site, but a lot of being well-led is essentially having a governance system that works and making sure that you're keeping things up to date and you are doing those risk assessments audits on time and they are generating improvements in your practices that are being dealt with in a reasonable time frame. iComply application success. So for those of you who are using the application, we've done research to go along with that research we've been looking at, and we've got 500 practices on the application now, and we've had 30 of those practices inspected in the last 12 months. Only one of them was told that they must make an improvement, and that was because they hadn't followed their own recruitment policy and that they hadn't got an enhanced DBS check for a new associate. So the research is showing that the application is working, and this work that we're putting into it is helping you out in inspections. And the feedback we're getting from practices is that inspectors do really like the system and it makes their job easier. Okay, so topics for today. We're doing a health and safety update. We're going to be discussing Safer Sharps and the Safer Sharps regulations and how you can meet those regulations in your practice and what the CQC are looking for in your practice. We're going to be discussing lone working, and there are multiple aspects to lone working. There's the HSE side of it and there's the GDC side of it. We've released documents this month to help you cover the HSE side of it, and we're going to release documents in the next few weeks to help you cover the GDC side of it as well. We're going to discuss the immunisations guidance, of which there are 4 documents, and it's a bit of a minefield, immunisations guidance. So we're going to discuss best practice and what you should be doing and what regulators are looking for, because there's a bit of a difference there. I'm also going to discuss and touch upon risk assessment forms and sort of common mistakes that we find with people using risk assessment forms, and hopefully give you some tips for using the updated version of our health and safety risk assessment. And then we'll take some questions at the end. So, Safer Sharps. So what are safer sharps? So the legal definition of a safer sharp is a medical sharp that is designed and constructed to incorporate a feature or mechanism which prevents or minimizes the risk of accidental injury from cutting or pricking the skin. So that's the legal definition, just in case anybody wanted to know. There's a European directive, and there's now an English law, which is the Health and Safety Sharps Instruments in Healthcare Regulations 2013. And what they state in these regulations are that you must ensure that the use of medical sharps at work is avoided so far as is reasonably practical. And we'll discuss a little bit more about what that means. If you do have to use sharps at work, then safer sharps are used so far as is reasonably practical. And essentially that you are not recapping unless you have done a risk assessment that says that recapping would reduce a greater risk than not recapping. And that if you do recap, you use an effective tool to do so. But generally speaking, you don't want to be recapping, which we'll discuss why. So CQC's position. So the CQC's done a dental mythbuster on their website, which you can go and have a look at, discussing the safer sharps regulations. And what they've said is that employers have to ensure that risks from sharps injuries are adequately assessed and appropriate control measures are put into place. So you've got to do a risk assessment. Now, if we go back to the regulations of what it said before, is it says that you've got to reduce the use of sharps in your practice as much as you can. Now, the way that this has been interpreted by everybody, the deaneries, code, other organisations, and the CQC as well, is essentially that you need to reduce the number of people using sharps. So essentially, there's no need for nurses to be handling sharps. I'm pretty sure we're all aware of this at the moment, but nurses shouldn't be handling sharps anymore at all. They say you've got to have a written practice policy and protocol in place, including a risk assessment. And if that you are using traditional sharps, you need to justify that in your risk assessment. You've got to substitute traditional unprotected medical sharps with a safer sharp where it is reasonably practical to do so. And if you're not doing it, as we just said, you've got to justify that in your risk assessment. Now, the issue there is what classes as reasonably practical. The argument that they would be more expensive to put safer sharps in your practice isn't a good enough argument for regulators. So you'd have to come up with a very good reason to justify the use of traditional sharps. It says the needles must not be recapped after use unless the employer's risk assessment has identified that recapping is itself required to prevent a risk. Now, if you're using a safer sharp system, generally speaking, you're not going to need to recap because that sharp system will have a mechanism in place that means that you don't need to. So best practice as well is that you're using single-use disposable local anaesthetics syringes to protect against accidental injury. Now, what does this actually mean you need to do in practice? Oh, sorry, we just had a question there from Harold, which is actually quite a good question. Does code have a specific sharps risk assessment? What we've just done, which we're about to discuss now, is we've updated our health and safety risk assessment to include sharp section and justification sections for if you are using traditional sharps and for if you are recapping. So you will justify why you are doing that. So it is there now in the system for you. And we'll have a look at that afterwards at the end of the session. So what have you got to do in your practice? Well, I've already covered most of this, but you need to minimize the use of sharps. So as we said, nurses shouldn't be handling sharps. You need to replace traditional sharps with safer sharps that include mechanisms to eliminate the need to recap wherever it is reasonably practical to do so. So that is British law. That's what the law says that you must be doing. If you are using traditional sharps, then you've got to justify that using the risk assessment, and there's a section for that in the new risk assessment for you in the updated version of M250B. And if you're recapping, as we said, you must justify that as well. So you then need to update your sharps policy. We've got an updated version 2 of the sharps policy is now in the system, M233 SHP, and you need to train your team. So you need to discuss if you are introducing safer sharps, or if you, for reasons you have decided that you're not going to and you've justified that in your risk assessment, you need to train your team on what you put in the risk assessment and what the safe way of using those sharps in your practice is, or are. Okay, so moving on from sharps to lone working. Lone working regulations, there's three sort of areas that need to be considered when discussing lone working. The first one is the Health and Safety at Work Act 1974. The second one is the Management of Health and Safety at Work Regulations 1999. And those are essentially the HSE, and that's what they want you to look at when you're thinking about lone working. And then there's the GDC standards and the CQC interpretation of the GDC standards. So you need to be complying with GDC standards and you need to be complying with health and safety laws. So we're going to cover the health and safety laws first and what that's about. So lone working definitions. There's a really good document that you can download from the HSE website if you want to have a look at it, which is you can see there the health and safety guidance on the risks of working alone. And there's multiple definitions of lone working in there, but for the purpose of a dental practice, the definition that I feel applies best to dental practice is that top one, which says people working on their own outside normal hours. So that includes your cleaning staff and obviously anyone who's in the practice late at night. So if you've got a manager working late on their own, or a team member staying late to do the decontamination. And obviously you see there's some detail there which is saying that working alone in itself is not against the law. However, employers need to consider carefully and deal with any health and safety risks for people working alone. So we've updated our health and safety risk assessment to include a risk assessment for lone working as well. And you've also got responsibilities for contractors and self-employed members. So obviously your associates and maybe cleaners as well. So you need to have processes in place and have done a risk assessment to assess, say, security risks of people working late and emergency risks of people working late. So action points. So what do you really need to do in your practice to comply with the HSE, the health and safety law aspects of this? Well, these are the documents that we've released recently. So you need to carry out a lone working risk assessment. So we've done that for you, or given you the the tools to be able to do that in the iComply system, and that's in M250B as well. We put that all in the health and safety risk assessment. You need to involve team members when considering potential risks and measures to control them. So if you do have team members, or that's employed or self-employed, who are working late, discuss what those protocols or those procedures, control measures would be to reduce those risks or eliminate those risks. So involve them in the process of creating your documents. You need to take steps to remove risks. Sorry, I should say remove, not move. You need to take steps to remove risks or put control measures in to reduce them. And that you will do through the risk assessment process. Once you've done all of that, you then need to create a lone working policy. And we've given you a template to do that, which is M233 LWP, which you can see on the right there, which we've put in a way that we think we may do it, but as always with code documents, these are templates. They're for you to adapt to your practice, and you may want to do it a different way, but we put a suggested procedure in there for you. And then you need to train your team on it. Obviously, as always with policies and procedures, they need to be living documents, not just documents that you've put on file to pass an inspection and tick the box. They need to be documents that you've trained your team on and they are aware of them and they know where to access them. So with the lone working policy that's new in the system now, for all new cycles, people with new iComply application cycles, this will be in their cycle. For anyone who's in their current cycle, it's in the news section, so you want to adopt this policy and just add it as any other business in your next meeting and train the team on how to deal with this. So lone working, the GDC and the CQC. So there's GDC standard 6.2, which says that you must be appropriately supported when you're treating patients. Now, the focus here is on medical emergencies and what would happen if there was a medical emergency. And there's two scenarios that they're looking at. And the first one is treating patients alone on the premises. And the second one is treating patients alone without chairside support. Which the first one is more to do with emergencies and emergency situations, but also to avoid routine treating of patients without a nurse chairside in emergency situations. And the second one is more to do with, say, hygienists and therapists. So we're going to discuss both of those now. So the CQC have quite helpfully published a new dental mythbuster on the 6th of May this year. And they've clarified their position on some of the loan working in addition to health and safety aspects that are looked at. And we'll discuss those, and then I'll tell you what we're doing at Code to help you meet those. So the first one is treating patients alone on the premises. What they've said is we would be concerned if our inspectors found dental care professionals working alone on the premises which are not covered by the exceptional circumstances stated in the GDC standards. If there are exceptional circumstances, which means you cannot work with an appropriately trained member of the dental team, when treating a patient in a dental setting, you must assess the possible risks to the patient of continuing treatment. And the other one they said is the GDC outlines exceptional circumstances as those which are unavoidable, not routine, and could not have been foreseeable. So absences due to, say, annual leave or training are not exceptional circumstances. So with the top one, what they're really trying to avoid, and we have this is covered in M233CHP, our chaperoning policy, but we are going to update that for you in line with this new statement from the CQC. So you'll see an update for that in the iComply system in the not too distant future. But what they're really trying to avoid is routine situations where you're dealing with emergencies and you don't have a nurse there. So that's mostly covered. The bottom one's the more important one, which is what they've said is, and this is angled at hygienists and therapists. They've said if our inspectors found, Rebecca, we are just about to cover that. It's a very good question. So they said if our inspectors found a dental care professional to be working alone without chairside support from a dental nurse, we would expect to see that a risk assessment had taken place, and this needs to take into account how support or assistance would be provided in a medical emergency for either the patient or the dental care professional. So there's two scenarios there that you need to think about, which is essentially if say, a hygienist or a therapist is working alone with a patient and there's a cardiac arrest, what is your procedure to deal with that? What are the risks there, and what measures have you put into place to minimise those risks to make sure that that emergency situation could be handled? And the bottom one, sorry, the second one is what would you do if something happened to the dental care professional? So let's say in the unlikely event that your therapist had a cardiac arrest whilst they were treating a patient without a nurse. Now, we are going to release a new document, which I think is going to be called M297, which is working without chairside support, and we're going to release a risk assessment to help you to deal with that situation. In the interim, what you may want to do is write up a document yourself saying what your procedure would be for that. So say if you did get a CQC inspection in the next couple of weeks, you've got something to cover that if your hygienists or therapists are routinely working without a nurse. They want to know what is your procedure for dealing with medical emergencies in that situation. Sarah, when's it being released? We've got it in draft at the moment. I'm actually going to be reviewing it this afternoon. I would say it's going to be released within the next 2 to 3 weeks. Okay. So, moving on to immunisations. Immunisations is, we've just updated iComply documents on this and we've just released them. And this is something that we've been reviewing and talking to experts about, at least 2 external consultants and 1 GDC expert witness since November, because it's actually quite a difficult area to figure out what you need to do to comply. There's actually 4 sets of guidance on this. We've got the health and clearance for tuberculosis, Hep B, Hep C and HIV for new healthcare workers, which came out in 2007. We've got the Department of Health Green Book, which was updated in 2013. We've got HTMO 105, and we've got the Code of Practice. And the question would be asked, which one is the relevant guidance? And the answer is actually all of them. But it really depends what the regulators of the CQC are looking at. Technically speaking, we should be complying in practice with all of these. So we'll go into the details of this, and I'll explain it because it is quite complex. So in summary, the Green Book states that all new employees should undergo a pre-employment health assessment and are offered immunisations as appropriate for their role. And this assessment can be done by the practice, so you could do that yourself, or by an occupational health service. So that's what the Green Book says. That's for all team members. All team members, whether they're admin or clinical. There are differences for clinical team members. According to the Green Book, all team members must be up to date with their routine vaccinations and have had chickenpox or vaccinated against it. That's all team members again. All clinical team members must have received the BCG vaccination and be offered influenza immunisation on an annual basis. There's someone there who's raised a point which I'm actually going to discuss that about occupational health. New team members who carry out so the top one's from the Green Book. The second point is from the Green Book again. The third point here is from the new Healthcare Workers Guidance, which was published in 2007. Now, this is where it gets a little bit more interesting because the CQC do not seem to be inspecting against this standard, whereas the Inspectorate in Wales are looking at this and the Inspectorate in Scotland are looking at this as well. So this is on their inspection documents. And technically speaking, this guidance came into effect and we were supposed to be following this since 2008. So it says all team members who carry out exposure-prone procedures, EPPs, must be tested and cleared for Hep B, Hep C and HIV. Now obviously that's quite an impact on that, and it's very difficult to advise you what to do in practice about this. We're making you aware of the guidance, but technically speaking since 2008, these checks were supposed to be being carried out. So additionally, HCMO 105 requires that all team members involved in decontamination are able to prove immunisation against hepatitis B. Now, I've discussed this, I think, in other webinars, but it's really important here is that they need to be able to prove immunisation against Hep B, which means they need to have had their injections and have a blood count that proves that they've seroconverted before they do any decontamination. So then obviously the other point is if a team member has hepatitis B, Hep C or HIV infection, professional advice must be sought from occupational health. And then, so what do we need to do in practice? Well, technically speaking, all new team members since 2007 should have been having these advanced checks, and it's all about what EPPs are. Now, exposure-prone procedures are, I'll read the definition here. They're those invasive procedures where there is a risk that injury to the worker may result in the exposure of the patient's open tissues to the blood of the worker, and obviously the reverse as well. These include procedures where the worker's gloved hands may be in contact with sharp instruments, needle tips, sharp tissues, inside a patient's open body cavity, wound, or confined anatomical space. So what do you need to do? So technically speaking, you should check the immunisation status of all team members, offer them the appropriate vaccinations and maintain records. And you can use our updated staff immunisation record form to do this. There's a lot of questions going on about occupational health at the moment, which I've said obviously is quite a tricky topic. So we'll discuss that now. So occupational health. The Department of Health, the Green Book again, says that employees need to be able to demonstrate that an effective employee immunisation programme is in place and that they have an obligation to arrange and pay for this service. Now, this doesn't mean that it has to be occupational health. That could be a GP who's doing these injections. Your duty is to check these things, and if they don't have them, it's your duty to pay for them for your employed team members. Now, whether you're doing that yourself or you're sending them to occupational health, either way, if they're getting checked against the Green Book's guidance, you'll be meeting the regulations on this. However, there's this line in HCMO 105 that says that all team members thought to be at risk of hepatitis B should have an occupational health examination. Now that's obviously quite tricky because we don't all necessarily have access to occupational health, and a lot of people will say, well, the NHS, our local NHS, don't offer occupational health services, which traditionally they did. So it's quite a difficult one to deal with because the NHS's position on this would be that as practices, we are NHS contract holders. We're private businesses, essentially, and it wouldn't be the duty of the NHS to provide these services to you for free. Which is why they've actually scaled this back. NHS trusts used to offer it, but you will find some GPs and some trusts will still do it for you, and some of them won't. So if you can get an occupational health service for free, fantastic. If you can't, then technically, if you're complying with HTML 105, then you should be sending your team members, your clinical team members, for an occupational health risk assessment. So we've said where possible, practices should set up arrangements with the local occupational health service to assess team members' immunisation needs and provide vaccinations. So hopefully that's cleared that up a bit. So we're on to the last point now, which is on risk assessment, and then we'll have a little bit of look at a risk assessment in iComply and how that looks, and hopefully it should be able to help you with the common errors that we find with risk assessments. So first thing with risk assessments is that they must always be carried out by a competent person. So in law, if anything ever happened and you ended up in a court, then they're going to ask, is the person who performed that risk assessment, if they found there was a problem with the risk assessment, which if done properly would have reduced the risk that caused the accident, they would ask, was it carried out by a competent person? So you can, there is training available if you really want to do it. There are one-day courses and there are online courses for free, I believe, if you have a look online. But obviously just make sure that if anyone's doing that risk assessment, you'd be happy to stand by that risk assessment if anything happened. When you're using a template, you've got to, our risk assessments are templates. So when you're using a template, you need to add or remove the risks as applicable to your practice. So we've put a list of risks on there, but some of them may not apply to your practice. And obviously it's not going to look good to an inspector if they see a risk on there, like say lasers, and you've assessed that risk and scored it, but you don't have a laser unit in your practice. The other one there is you need to add or remove control measures as applicable to your practice. So if you, we put in lists of the risks and the control measures that you could have in place, but those are template control measures, things that we think that most practices would have, but you need to add or remove them. So quite often my team will go into practices and what we'll see is people have just signed off the risk assessment and scored it, but they've got control measures in there that they don't have in the practice. For example, on the sharps section, they'll have the control measure of safer sharps are used in the practice, but then there's no safer sharps in the practice. So that would look to an inspector looking at your practice that the risk assessment hadn't been done accurately, that you just tick the box to try and do a risk assessment because you know you need to do one to pass an inspection, rather than doing it for the legal reason that you need to do it. And then the last point, which is a really important point, I've probably touched on this in other webinars, is that if you're using any external risk assessment companies, then make sure that you read the risk assessment and you address the suggested actions. I've read CQC inspection reports recently where they've said on the inspection report that the best one was the practice should implement the 31 action points suggested in their Legionella risk assessment from 3 years ago. So obviously they've got the risk assessment and they've put it on file, but they've never read it. And the same with, say, if you're getting an acceptance test or critical exam when you get an X-ray installed, have a look at the report that comes back, because we've been into practices where there have been issues on that report that need to be dealt with. So just a key takeaway from this is anything you get done externally, have a look at it. But I think I've covered that in most webinars. Okay, fantastic. So we've covered the immunisations, the loan working, and we've discussed the new documents that we're going to be releasing shortly, and we're going to update our chaperone policy to help you meet the CQC's new statement. And we're also going to release a new module and a risk assessment for working without chairside support. So hopefully that was really helpful for you. I just want to have a quick look in iComply now, just to show you this general health and safety risk assessment and point out those things that we were just discussing. I'm inside iComply now. As everyone knows who uses iComply, obviously we set up a cycle of compliance for you for 12 months, but things do change and we get new changes to regulations. For example, that statement we just discussed that the CQC have just released on the 6th of May, and we're going to react to that very quickly and get documents out for you. But we've just done, the reason we're doing this webinar was obviously to help you with this spring update that we did. And and you can see down here, we put that in the iComply news view. So for those of you who don't use the application, whenever we do anything like this and we release new documents, when you log in, it will be there for you in the news with instructions on what you need to do. So you can see here that we were just discussing the new loan working policy to help you meet the HSE guidance, a new Sharps policy to help you comply with the Sharps regulations and what the CQC are now and other regulators are looking at. We've updated our immunisations guidance, and that pretty much covers everything that I've just been discussing with you. And there's an immunisations record as well down there. But the one I want to discuss obviously is this health and safety risk assessment, and just point out those things on the risk assessment. So what we need to do is we just go over to the document section, which is here, template documents, and we're looking for the health and safety risk assessment M250B. So if I just click on template documents, click on search, I'm going to put in M250, and that's brought up the health and safety risk assessment there. So I can just click on this directly, it's a hyperlink, and that will download the document for me. So I'll just do that now. So I now click on the health and safety risk assessment in the Word document, and there it's brought it up for you. And I'm just going to expand that so people can see that, and hopefully everyone can see that on the screen. What I wanted to discuss obviously is there were two sections here. The first one is these identified hazards on this section here. So as I said earlier, we've identified the hazards that we think are in most practices, but there may be some hazards that aren't applicable to your practice. So you'd want to remove those sections from your risk assessment. So if I scroll down, then what we'd see is a good example would be this one here for lead foil. So if you're not using traditional X-ray film in your practice, then you could just select all of that. Oh. Sorry, I'll just scroll back down. Editing wasn't allowed. You just select all of that, right-click it, and just delete the entire row. Take it out of the risk assessment. If there are any risks or hazards that you feel you need to add, then obviously it's a template and then you can add them. You could add a row to do that as well. So make sure you're taking out any of the risks that don't apply to you. So further down, we'll have gas cylinders. Well, actually, sorry, we'll have oxygen cylinders. There's laser beams, which you can see here. So you might want to remove the whole laser section. The other really important thing that you can do is you need to remove the control measures. So when you're talking about risks, you're assessing risks, and then you're saying what control measures you're putting into place to reduce those risks, and if there's any further actions required. So this column here, as you can see here, is the control measures. So if we go down to, say, the Sharps section, then you can see here that we're talking that the risk is a Sharps injury, and there's possible control measures in this column here. And you can see we've actually put safer Sharps are used here. But you may not have safer Sharps in your practice. You may have done a risk assessment and decided that you're not going to use them and you're going to justify them. So you'd need to remove that as a control measure, because otherwise it's going to make it look to an inspector that you haven't done it accurately, that the control measures aren't in your practice. Same if you're doing any other risk assessment. I think it's on our information security risk assessment when we're talking about building security. We put in control measures there that say that you might have a CCTV system. And quite often I've seen that hasn't been removed by practices. So you want to make sure that the control measures are accurate, and you need to remove those. The other thing, just to show on this risk assessment, is we've added for you at the bottom here justification sections for justifications for the use of traditional Sharps and instructions to reduce the risk of injury. So you would justify there to show an inspector and to meet the regulations why you're still using traditional Sharps. You'd have instructions there on how you're going to reduce injuries if you've made that choice. And below there, obviously, we've also got justification for the recapping of Sharps and instructions to reduce the risk of injury.